Good afternoon, everyone, and a very warm welcome to everyone who's taken the time to join us today for our Let's Talk About Cauda Equina webinar. My name's Lindsay Tomlinson. I'm one of the partners in the medical negligence team at Irwin Mitchell, and I've got the pleasure of being your host this afternoon for this session. And I'm pleased to be joined by my colleagues Julianne and Gurpreet. Together, we're part of a team of solicitors at Irwin Mitchell who act for clients who've suffered from a delay in diagnosis of their cauda equina and other spinal injury claims. And through the work that we do together, we see the impact of cauda equina on our clients and the importance of timely and well thought out rehabilitation and support. As many of you know, the topic of cauda equina itself is vast, and that's why we've created this series of webinars. This is the third webinar in our series, Let's Talk About Cauda Equina series, and we're pleased to welcome back people that may have attended the first two. In the first webinar, we looked at the importance of early diagnosis, and in the second webinar, we looked at how to identify the early signs and symptoms of CES. In this third webinar today, we're looking at the importance of rehabilitation and support for patients. And we have a fourth webinar scheduled for early in the new year for details that we will put at the end. So just in terms of the running order for this afternoon, we've got a fabulous panel of experts joining us, and we thank them for giving their time to join us today. First, we're very privileged to hear from one of our clients, Angela, who's going to talk with my colleague Julianne, her solicitor, about her story and cauda equina diagnosis. Our second speaker is Damian Smith, a spinal cord injury specialist nurse who is now with the SIA and will look at the initial discharge and support from the SIA perspective, as well as the new suspected cauda equina syndrome pathway that he's been supporting on. And then we will have a short comfort break for 5 minutes before our third and final speaker, Mark Buckingham, who's a physiotherapist who will look at the importance of physiotherapy in the rehabilitation process. At the end of the three sessions, we will have a panel discussion chaired by my colleague Gurpreet. Because we're trying to make sure we stick to time for our 1.5 hours, we won't have time for questions directly to the speakers after their presentation, but they have very kindly agreed to stay to the end, and we can deal with any questions that you have in that Q&A panel discussion at the end. If you have a question, if you can put it in the question and answer function on the screen, and we'll make sure we answer them. If we don't have time, if you could leave your name and email address so we can respond directly to you post the event. Although, of course, if you want to post anything anonymously, any questions, if you prefer to do so, then please do, and we will try and get through all of the questions that we can today. We will be recording the event, so and it will be sent out to everybody who's signed up to the webinar. We're aiming to keep to time, but if you have to leave or we're overrunning, then you'll be able to catch up from that recording. And there will be a chance for feedback at the end, so we'll be posting a feedback in the link. If you could just take a couple of minutes to let us know your feedback on the webinar and any further topics you'd like to hear from us about, so that it really helps us planning our next webinars in this series and anything else spinal cord related. So that's enough housekeeping and from me. Let's get started. I will introduce our first speaker. Absolute pleasure to introduce Angela and her solicitor Julianne. Angela runs her own business as a textile artist and is a successful designer, teacher and author. She's had cauda equina syndrome since 2018, which impacts her on a daily basis, and we're very grateful to her for helping set the start of this webinar with a personal story about the importance of having the right rehabilitation and support around you from the earliest opportunity. So I will hand over to Julianne and Angela. Thank you both.
Thank you so much, Lindsay, for that introduction. As Lindsay said, we wanted to start the webinar today by sharing a bit of a lived-in experience to help sort of set the scene about the importance of that early rehabilitation and how it impacts on clients and patients alike. And we're extremely grateful that Angela has agreed to kindly share her story about her life with cauda equina, what happened and how it's affected her. And as Lindsay says, Angela was diagnosed with cauda equina back in 2018. So really pleased that she's agreed to come along today and share her story. So Angela, welcome. Thank you very much for joining us today. I thought it'd be quite useful just for you to set out a little bit about what your life was like beforehand, before you had your diagnosis of cauda equina.
Right, thank you for inviting me. It was a very busy life. I had transitioned from being a full-time primary school teacher through to running my own business. And my business really involved teaching up and down the country. So, you know, one day I could be in Scotland, the other day I could be in London. So I was constantly on the go, really, with travelling. As well as that, I used to independently go and see parents and care for parents. I had done marathons. I was horse riding at that point in time. So it was just a really busy, full life, really.
Yeah, thank you for that, Angela. So can you take us through about what happened when you started to develop symptoms?
I had what was diagnosed as sciatica for about 2 to 3 months, which was getting progressively worse. At that point, I'd had no other of the red flag symptoms. And because it was getting worse, the GP just wrote it off for quite a long time. And then I was sent to physio for the sciatica, which was about 10 days before the event, as I call it, happened. And that event was that I got up, went to the toilet and got the most excruciating lower back pain. I describe it as worse than childbirth pain. And that was sort of the pivotal moment, really, to my cauda equina journey.
Okay, and I know eventually, Angela, that you went to hospital, didn't you? So can you sort of tell people about what happened when you went to hospital?
Yes, so that's where it kind of went a bit, I don't want to say wrong, but I went to hospital by ambulance. In total, I spent 18 hours in A&E. They didn't know what was wrong with me. I was told it was just a bad back. And I was discharged. So I think I'd been in about 8 hours and they discharged me. But at that point of being discharged, I couldn't walk, I couldn't go to the toilet. There were lots of things going on, but obviously I hadn't heard of cauda equina syndrome at that point. But because they told us to go, my husband had to find a wheelchair and we went to pharmacy. And at that point, I collapsed again. So I collapsed in a corridor in the hospital, and then there were some doctors who just picked me up and rushed me back to A&E. And I can still hear it now, of a really strong voice memory. And I don't know whose the voice was, of somebody saying to me, "Why has she come back in? We've discharged her." I don't know who it was, but it still makes me go cold now. So then I was in a bed in the corridor and just waited and waited and waited. Towards, I think I'd been in there another 6-7 hours, and then a very young doctor, her junior doctor, came to examine me, and then he said that I needed to be looked at. So he went off and came back with two doctors from the orthopaedic ward. No mention of spinal cord injury or anything like that. But then I was told that they were going to admit me. Again, they didn't say why, they just said I needed to be admitted. And it was, so that was sort of on the Monday. And then at that point on the Tuesday, I was booked for an MRI scan. I didn't have that until I think Tuesday afternoon. And again, they didn't tell me the outcome of that, but I was told then that I needed an operation and that they couldn't do the operation. I had to go to a hospital in Nottingham that did the operation. But no mention of cauda equina, no mention of the fact that it had to be done quickly, because by this point I was cathetered and I had very limited sensation in my legs and I really was quite unwell. I was told that I would go to Nottingham on Wednesday, and I didn't actually go until I think 26 hours later for the operation. So it was quite a long time from going in early hours of Monday morning to being transferred to a hospital for the operation, which was I left my hospital about midnight on the Thursday, so I got to Nottingham early hours Friday morning.
Thank you, Angela, for sharing that. And it was a very, very long period. When you were eventually told, in fact, that you had cauda equina, were you told after the surgery or before the surgery?
No, it was after the surgery, and this nurse came and she gave me a leaflet.
Okay, and what did that leaflet say?
It just said about cauda equina syndrome, and I'm lying there and I see words like incontinence, lack of sexual function, all of these big words, and panic sets in because nobody was talking to me about this. I just had a leaflet. And then, of course, you start to Google things, and I just had to figure it all out for myself. And whilst I was there, I met somebody called Chris from the Spinal Injury Association, who kind of became my guardian angel because he followed me around 3 different hospitals. And it was actually him that explained about it. And it was actually him that explained that you can live a life with intermittent catheters, you can manage your own bowel care. There was no medical professional explain that to me. It was just him. And when I asked the nurses didn't know what it was. They said I had to email the nurse, I had to email the person on the back of the leaflet. When I spoke to the surgeon, they were just more interested in the wound healing and things like that. But I did end up back in my own hospital, but then I did end up in a spinal unit, and I now realise how lucky I was to get into a spinal unit.
Okay. And what, following your surgery, what sort of rehabilitation were you given?
I had nothing. I was moved from Nottingham to my local hospital, and I actually felt very old because the physio came to me and he said, "Hello, Mrs. Damon, do you remember me?" And I taught him when he was 4. So that was a bit like, oh, okay, and I'm there looking awful in the bed. But he'd researched it, so he tried to give me physio, and he was trying to get information to help me, but I didn't really have a lot there. But I know that Chris from SIA contacted somebody at Sheffield, and I miraculously was taken by ambulance from Boston, Lincolnshire to Sheffield. And in Sheffield, it was just so, because it was a spinal unit, there were physios, there were OTs, there was so much support there for bowel care, for bladder care. And I'm getting emotional now. Now I look back and I think I had a really good rehabilitation. However, I was one of the few, I believe, that do get into a spinal unit.
Yeah, I think we see that certainly from our experience with some of our clients that we talk to. If you can get onto a spinal unit, that really does change your rehabilitation. But unfortunately, there's not always. Some people don't want to go because it's too far away from where they live, but also there might not be a space on the spinal unit. So pleased to hear that you got to Sheffield. So how long did you stay in Sheffield for?
I think I stayed nearly 9 weeks. So I think in spinal injury terms, that wasn't that long, but it did feel like a long time being so far away from home.
Yeah. Okay. And did you find that sort of rehabilitation on the spinal unit, absolutely, essential and sort of really informative?
It was definitely, because you were with people that had spinal cord injuries, and you were with nurses and doctors who knew about it, who knew about cauda equina syndrome, who were giving me the information that I was so desperately needing. And to hear it from medical professionals rather than something that you've Googled, it almost felt, although it was horrendous, it felt validating that this had happened to me. And I was getting support, and not only physio support, but occupational therapy support as well, about doing things at home, transferring in and out of cars, and realising or that helped me to realise that I can go back, and although it would be difficult, I could kind of resume my life again, if that makes sense.
Yeah, it does. And once you were discharged back to the home, what was the sort of rehabilitation like then? Did that sort of drop off, or
it totally dropped off?
dropped
Yes.
off? Yeah. And so what did you do in terms of, I know you've been paying for some private physiotherapy, haven't you? What other things have you been doing in terms of rehabilitation?
It's mainly the private physio, because when I did come home, I did have some OTs come into the house, but they'd never worked with anybody with a spinal cord injury. So they bought these big toilet seat things, and they were saying, well, you have to use this, and I'm like, I can't use this. And they admitted that they had no experience at all, but they'd been told to come and see me. I also was sent for some not private physio, and the girl, who was very young, had no experience of spinal cord injury, and she said, tell me about your episode. And she thought, she said it was probably all in my head, and if I didn't have any aids with me, I possibly could walk, because it was all in my head. So I was extremely lucky to find a private physio who's had experience of working with spinal cord injury people. She also does acupuncture, which I do find helps me. And I was also very lucky to find a private podiatrist as well, because I've had lots of issues with my toes and my feet. So that's really helped as well. But all of this I have had to search for, and I've had to fund privately.
I think the message is that in terms of, it sounds like whilst you were in the spinal unit, you had some good rehabilitation, but as soon as you were discharged back into the community, that it kind of dropped off a cliff, and you had to sort of, do your own kind of searching for professionals, etc. So what message would you say to people on the webinar today in terms of, having that good discharge and wanting to sort of maximise your opportunity?
I think to realise it is an extremely scary time, that you're coming out of somewhere that you've been supported, and all of a sudden you're having to do everything yourself. And I was never told about the fatigue that comes with spinal cord injury. I was never told about the two different types of pain that come with it. And although it's a rare condition, I think it's believing in what people are telling you.
Okay. And just in terms of, you talked about your life, what it was like before you had Cauda Equina. What's been the impact? And obviously it's a few years since you've been diagnosed, and you've been very self-resourcing, trying to, improve your outcomes. But how has that kind of impacted you on, how's your life changed really since that diagnosis?
I think it's changed hugely. I'm quite a stubborn person, so I think I've tried to carry on, but I didn't think it would still be. Every day is a challenge, every day is difficult, and sometimes just the energy it takes just to get up and get dressed, you feel like you've spent your energy for the day. I still try and do what I did with teaching and things like that, but often it's physical accessibility. It's even physical accessibility sometimes trying to see medical professionals. I find the fatigue really limiting, so I can't do what I did before. Everything is planned now, because obviously with no bladder or bowel control, it's constantly trying to work out where the toilet is, so journeys have to be planned, and everything now is micromanaged. There's no spontaneity or anything like that. It's very hard to cook with the chronic pain. And I think one of the things that I still struggle with is people's assumptions of me, because I do a lot. I used to do stuff on the television. I still go out and do big shows, which is where you get sort of a stitching show where 10,000 people will come through the door, and people talk to me in a loud voice.
Right.
People, I'm sitting at my stand and somebody says to me in a loud voice, "This is good, this is simple, you might be able to do this." And when you say you're the designer, they just go, "Really?" I've sat in front of, not now because people are used to me, but in the early days, I'd get upset because I'd sit in front of 20 people with a lanyard on, and it would come to the time to teach, and people would be looking round saying, "Where's the teacher?" And I'm like, "I'm here." I think it's been hard because my husband has become my carer, so that's been quite hard because he didn't sign up for a wonky knee. So Cauda Equina hasn't just been impactful on me, it's been impactful on my family as well.
Thank you for that. I mean, I think you've said about the sort of, that early support from the SIA. Have you benefited from any other support at all along the line? I mean, it sounds like, their support was absolutely crucial, wasn't it? It was a sort of turning point to certainly even getting you onto the spinal unit.
It was hugely. I've had support from backup because exactly a year to the day that I had my spinal cord injury, I was abseiling down a rope in the Lake District with backup.
So yeah, we were talking about that, weren't we, the other day? And I think we've got some pictures. I think we're going to share those of you doing that. Absolutely a fantastic challenge, because you're one individual that won't let your disability define you. So do you want to talk us a little bit about what you did on that challenge on that day?
Yes,
Angela.
so all the equipment I use, I've had to self-fund. I did get a very big wheelchair initially from Wheelchair Services, but then I was told that I don't fit the criteria, so they never gave me a small wheelchair. So I was fortunate that we had savings that we could do that, and not everybody has that. And when I do the shows that I've just talked about, it's just so physically demanding on my shoulders. I don't know if you've ever been to the NEC in Birmingham, but if I teach there and I do a show, sometimes it can actually be a quarter of a mile from where my stand is to where I go and teach. And if you're going back and 2, 3 or 4 times a day, that's a lot of pushing with my shoulders. So I decided to try and raise some money for an electric wheelchair attachment, which is just an electric unit that clips under my wheelchair. And I decided, in my infinite wisdom, it would be a good idea to go up and over the O2 in London. They were amazing. You can see that I was in their wheelchair there, and one of the photos on the left is my husband and my son, who have been amazing throughout all of this. However, if I'd have known that the pathway they pull you up is rubber and it was 3 millimeters thick, I don't think I'd have done it. I was up there thinking, this is too much information, I don't need to do it. But the sense of accomplishment I got, even though I was being pulled and pushed and manipulated, and all I had to really do was sit and move my safety harness along, was amazing. Because when I was up there, I thought, actually, Cauda Equina syndrome isn't going to define me, because I'm still me. This has happened to me, but I'm still me inside, and I can still run with stupid ideas and and still do fun things. But it was an incredible experience, and because I was in the chair, they take you up as a small party, so the only 3 people up there were my husband, my son and I. So we were left for about 15 minutes at the top just by ourselves, which was incredible, really.
That's an absolutely
yeah,
fantastic achievement, Angela, and the pictures, really sort of, show what went on that day. So,
it was a good day. So when I first came out, I remember just thinking I wouldn't have any good days anymore. Life is too difficult, and life is so hard. And I don't sometimes think people I've spoken to realise that there are so many different elements to living with Cauda Equina syndrome, in terms of nerve pain, ache pain, physically getting about, wear and tear on other parts of the body. But I look at that when I'm down and think I can still do things. It's not going to define me.
That's so great. Thank you so much, Angela, for sharing your story. And I know obviously it's difficult to keep going back over everything that happened, but I think you're a complete inspiration to us all and most people on this call as well. And it's really powerful to hear firsthand about, you know, Cauda Equina, how it's impacted you, and obviously, you know, what challenges you set yourself to sort of overcome that as well. So thank you so much for taking the time and sharing your story, which I think everyone's enjoyed listening to this afternoon.
Thank you.
Thank you. And I'm sure if you've got any questions for Angela, you can obviously post them in the Q&A. So I'm going to hand back to Lindsay now.
Thank you. Thank you so much, Angela, for such an open and honest account. I know it was incredibly helpful to everyone who's joined us in helping to understand that patient perspective, and I'm sure everyone will be inspired by such incredible tenacity that you've shown. I think everyone will agree Angela's story has really brought home just how important support is to someone faced with Cauda Equina diagnosis in helping them understand their condition, not just giving them a leaflet, and the importance of really good early rehabilitation and support from the right specialists. And it was really good to hear just how, you know, the guardian angel of the person from the SIA, which is a good way into our next speaker. So I'm very pleased to welcome Damian Smith from the SIA. Damian's been a nurse since 1993 and then worked for 25 years at the Duke of Cornwall Spinal Treatment Centre, developing a community liaison role, supporting patients after discharge and working with the healthcare professionals involved in that care and looking at training for patients and all relevant staff. In 2020, he joined the SIA, where he supports the clinical team in developing and delivering training on all aspects of spinal cord injury. And 2 years ago, the SIA merged with CES UK, and so the support that SIA can now offer to those with CES has grown considerably. And more recently, Damian has been the SIA representative supporting the development of the newly launched NHS Suspected CES pathway. So I'm delighted to welcome Damian and to hand over to him.
Thank you very much, and yeah, thank you for the opportunity to speak to you this afternoon. I'll just go and share my screen. So just firstly, I just wanted to just very quickly touch on some of the points that Angela made, because there are quite a few there that sort of resonated with me, and also just, you know, what SIA can do to support people with Cauda Equina syndrome, and just some of the challenges that people face, you know, with Cauda Equina syndrome, like the fatigue, the bladder and bowel issues, that, you know, life does have to be more planned. You know, how it impacts not just the person with Cauda Equina syndrome, but how it impacts friends and family as well. You know, these are things that SIA can support with. It did make me smile, not in a funny way, but when you mentioned about the leaflet, I've just finished producing a leaflet for Cauda Equina syndrome, which is with the designers ready to be used. So it's all good to go, but rest assured, I would not be just leaving a leaflet with a patient. It's there for information, but I'd like to think that we'd be talking around it as well. It's more just for information for somebody to remember, you know, parts of the conversation that I would have had with them. And certainly, you know, not being provided with the right wheelchair. I've just done some work with the Wheelchair Alliance and another Cauda Equina group to look at just like a template letter for GPs to use for wheelchair services, to make sure that people with Cauda Equina syndrome do get the right equipment. So, you know, these are just, you know, a few things that SIA can support with, and I'll touch a bit more about that towards the end of the presentation. But I think you've already been given a little bit of my background, and I know from the biography that I, you know, sent to Erwin Mitchell, a lot of that information you've got already, but I just wanted to sort of put it into a little bit of context about what some of the various aspects of my background are, and just sort of how they do relate to sort of the changing demographic of people with spinal cord injury, Cauda Equina syndrome. So I did graduate in 1993. I didn't go straight to the spinal unit. I spent about 2.5 years working in a care of the elderly setting. Initially, thought I'd just go there for 6 months and use my nursing qualification as a passport to travel. But that, circumstances changed, and I realised that I needed to work in a more acute area. And I had no experience of spinal cord injury up to the point that I joined the spinal centre, but it seemed to tick all the boxes that I was looking for. As a mixture of acute, young, old, male, female, rehab. So it ticked a lot of boxes. So my plan was, again, just to stay for perhaps a year or so and then move on. It took me 25 years to move on, and it was a job that I absolutely loved. As well as being a spinal cord injury specialist, I was also tissue viability lead for the spinal centre. But I also used to run the Cauda Equina clinics, which were nurse-led clinics. The consultants that I worked with, I think they felt that Cauda Equina syndrome is a lot more straightforward than spinal cord injury. It soon became apparent that there are a lot of complexities with somebody with Cauda Equina syndrome, and that people with Cauda Equina syndrome, they don't necessarily fit the box that I think the consultants thought they would, with the way that their presentations of bladder and bowels, for example. So I absolutely loved my time in the NHS on the spinal unit. But the opportunity came to join the Spinal Injuries Association in November 2020, which, you look at the dates, was slap bang in the middle of a pandemic, and it did seem a bit of a crazy idea to leave a job that I loved in the NHS, and the benefits and securities that go with that, to go and work for a charity. So it was a bit of a leap of faith, but I was very reassured. As an organisation, it's very well run. It's continuing to grow, continuing to expand, and it just meant that I had a much further reach with the sort of skills and knowledge that I have got, to be able to impact more people. So we merged with SIA merged with CES UK in January 2021, and overnight we acquired about 1,000 to 1,200 members with Cauda Equina syndrome. So although we'd already been supporting people with Cauda Equina syndrome, this was quite a landmark occasion. So I was very aware that the advice, information and support that we offer, we really needed to look at that again and sort of put that with as much importance as the work that we do with people with spinal cord injury. I was asked by my manager if I wouldn't mind stepping in for a meeting, which was the first meeting for the suspected Cauda Equina pathway development, which I dutifully agreed to. And then I fed back to him afterwards, and then I think he realised that although he's got a spinal cord injury, his knowledge of Cauda Equina wasn't as good as he thought it was. So I was therefore volunteered to become SIA stakeholder for the suspected Cauda Equina pathway. And it was really interesting just to see how that sort of manifested itself and how it all panned out. And I guess sort of with my slightly cynical side, I thought this would just be a very long project, and whether it would even see the light of day, but it absolutely did. And I was quite surprised at how fast things actually did move as the whole process went along. But I think it's worth just asking the question first off, why do we need to talk about Cauda Equina syndrome? Well, I think very simply, there is still a very large lack of awareness and understanding of what Cauda Equina syndrome actually is. And for some people, you'd probably be sort of quite familiar with the graphic in the middle there, which are the Cauda Equina red flags. Because of the lack of awareness of Cauda Equina syndrome, patients aren't often diagnosed correctly. Many patients that go to see their GP may be dismissed as back pain. Subsequently, there can be delays in diagnosis. And if there's a delay in diagnosis, there's going to be a delay in treatment. And, what we do know is that the earlier someone can be diagnosed with cauda equina syndrome, then the earlier they can be treated and the outcomes are much better. And just on the right hand side of that slide, just a quote that I pulled, that the average GP, they may only see one case of suspected or confirmed cauda equina syndrome every 4 to 5 years. So that's not many throughout their career, and people with spinal cord injury and cauda equina syndrome, they all present very, very differently, even if they have the same level diagnosis. The presentations can be quite different. So your GP might see one person with cauda equina syndrome at a particular level, and then they may see somebody else with the cauda equina syndrome at the same level, but the presentations could be very, very different. So often there is no rule book when it comes to the advice for people with cauda equina syndrome. You really do have to look at that individual, what their presentation is, and then you put your assessment together based on that with the advice that's then given. But we also know that people with cauda equina syndrome, they don't always have access to specialist care and advice. As a sort of vague rule of thumb, it's only about 1/3 of people with cauda equina syndrome or spinal cord injury that get treated at a specialist spinal centre. So at SIA, we support everybody with a spinal cord injury and cauda equina syndrome, no matter what the cause, no matter to what degree it is, or whether there's any other comorbidities attached to that. So I think those are pretty much the reasons why we need to talk about cauda equina syndrome, because it's not until we can raise more awareness and that people understand the impact of cauda equina syndrome, what those red flags are, what the pathway should be in order to treat it. Because I think if people do fit into that pathway, then the outcomes will be much better. We're not going to banish cauda equina syndrome, but I'd like to think that we'd be seeing fewer people with cauda equina syndrome in the future, because they will have been diagnosed much earlier, they will be treated much earlier, so there will be better outcomes. So I just want to give an example of a case study of a lady that I'm still supporting, and this isn't necessarily the norm, but it's not unusual either to come across situations like this. So last year, this 73-year-old lady, she went into her local hospital, previously very, very fit, independent, active, but she had a complex aortic aneurysm that needed surgery. The surgeon preoperatively didn't discuss with her the risk, or didn't discuss all the risks of having the surgery. Certainly it wasn't explained to her that by having this surgery, she could be left with some neurological deficit. So surgery was carried out. To all intents and purposes, the surgeon was very happy, with the outcome of the surgery. The aortic aneurysm was repaired. Post-operatively, she had an indwelling catheter in, which was removed on the day of discharge, and she was discharged home and essentially discharged from the surgical care. She was later readmitted 5 days later because of urinary retention, fecal incontinence and weakness in her legs. So she went back into the hospital that she'd come from. An indwelling catheter was reinserted, and then she was transferred to a care of the elderly ward. There was no neurological assessment carried out, and there was no referral to a specialist spinal centre. It was at this point that her daughter was doing her own research into these symptoms, and by pure chance found me on LinkedIn and contacted me directly through LinkedIn, just asking for support for her mother, which I was very happy to do. So I'd arranged with her to go and visit her mother and liaise with the medical team. So at this point, there was even the basic care wasn't managed effectively. And I'm being very careful about how I choose my words, because she was very well looked after within the scope of understanding of the team that were looking after her. But the fact she was on the care of the elderly ward, she wasn't on a specialist ward, although the hospital that she was in is a major trauma centre where they do deal with patients with spinal cord injury. So a lot of the investigations weren't carried out at this point. So after speaking to the medical team, I did advise that if they could carry out an ASIA examination, to look at her neurological deficit, that would be really useful, particularly for me to be able to then give more specific advice about the rest of her care. So the ASIA examination was carried out, but unfortunately there was an incorrect neurological diagnosis on there, which became very, very apparent because on the ASIA examination, the diagnosis that they put was a complete diagnosis, which meant that the level that they'd identified on the ASIA examination, that this lady shouldn't be walking. But halfway through my conversation with her, she got up, walked off to the toilet, and then came back. So immediately I'm thinking, well, that doesn't tally with the diagnosis that is given in the medical notes. So I did speak to them about that, and I did encourage them to refer her to the Regional Specialist Spinal Centre for an outpatient assessment, where also the acute outreach team could review her, because she did meet the criteria to be accepted under their care. She wouldn't necessarily go there as an inpatient, but I thought it was very, very important that she was at least under their care as an outpatient, where she'd get that long-term expertise follow-up. So that was all done. Another ASIA examination was repeated, this time with the correct diagnosis in place. So I was able to be more specific about, the advice that I was able to give. She was then discharged from there or transferred to a local neurological rehab centre, where the care and support was absolutely phenomenal. It was excellent. The staff were very open to any advice, because all of a sudden they're dealing with a patient that they're not familiar with her condition. So any advice and support that I could give was greatly received. So we commenced her on transanal irrigation. At this point, we decided to keep the catheter in, but to use a flip flow valve to, cycle the bladder. And she was discharged to a new home because the home that she was in previously, it just wasn't suitable. It wasn't accessible to her. So she's had quite a journey already. So after being in the neurological rehab centre, with the advice of the transanal irrigation, I thought that'd be a pretty straightforward transfer of care into the community. But the community services are private community nursing services which are commissioned by the NHS. So although they do provide support with transanal irrigation, they only do that in the early stages. But they weren't able to provide daily support as I'd requested. So we did agree that we would trial an alternate day regime to see if that would work. But also they couldn't commit to a time period, to a sort of small time frame where they'd be able to go in on any given day. It was essentially a 12-hour window period, for her to wait at home for the community nurses to attend. And some days, for various reasons, they couldn't provide support. And then after 3 months, she was given formal notice that they were going to withdraw her care for the transanal irrigation because it wasn't a service that was commissioned long term. So this sent me down another route, discussing this, with the private community nursing service, discussing it with the GP, with the continence team. We weren't progressing in the way that we would have liked. So the patient was advised to contact the CQC to raise, an issue through that route. But then she was referred back to the local health ombudsman, and the ongoing support wasn't really readily available. But the community nursing service, they did agree that they would continue to provide that support until alternative arrangements could be made. And what their suggestion is that she could fund her own care via an agency. You know, we worked out, you know, the costings, and it would have cost her over £400 per month to fund her own bowel care, which personally I didn't feel that would be acceptable, because I thought that should be a service that the NHS should be providing. So as it is at the moment, she's now on a waiting list for a colostomy. She didn't want to have the transanal irrigation, but she realised that because of the nerve damage, it was an appropriate thing for her to have. But with the situation as it is at the moment, and the inconsistencies with, you know, the care in the community, and also the fact that the community nursing services aren't commissioned to provide that care long term, she has opted to have a colostomy. She is under the care of Salisbury Spinal Centre as an outpatient, so she's receiving support from them, as well as ongoing support from the Spinal Injuries Association. So is this a normal scenario? Is it acceptable? Has anything changed? Well, yes and no is the simple answer. It's not a normal scenario, but I probably hear too many cases where the patients aren't necessarily sort of following the correct pathway to get the right support. If she was under the care of a spinal centre from day one, pretty much, then she would be on a more recognised pathway, so that support would be there. But she wasn't, so as the image on the right hand side, it was a bit like walking through a maze, you know, sort of hitting various dead ends, just trying to figure out, you know, what her care should look like, who can support her, where to get that support from in the first place. And if her daughter hadn't found me through LinkedIn, you know, potentially that whole situation could be a lot worse. So I think one of the highlights of my career, if you like, is that to be involved in something like the suspected Cauda Equina pathway, it was quite a proud moment to actually, you know, A, see the launch of the pathway, but B, see the fact that SIA is very much an integral part of this pathway. So the whole pathway itself, you know, starts from, you know, the point of, you know, the symptoms first being displayed, and it's very clear as to what, you know, that process should be as far as investigations, treatment, the aftercare, and then the post-operative care as well. And it's the post-operative care which is where SIA tends to fit in. So essentially 6 weeks post-surgery, part of that review process will be if that patient's still got ongoing symptoms of Cauda Equina syndrome, at that point they are then referred onto the National Spinal Cord Injury Database, so essentially referral to a specialist centre, and they're also made aware of the various support agencies that can offer additional support as well. So, you know, that would include us, that would include the Cauda Equina Champions charity. And as far as, you know, our input, where we fit into that pathway, it's very clear that if those patients require psychological support or advice regarding sexual function, bladder and bowel care, then we are one of those go-to organisations that can provide that care and support. We're very lucky in respect that, you know, when it comes to psychological support, we have trained counsellors that also have spinal cord injuries themselves, and we are looking to expand that service. But by those patients with Cauda Equina syndrome, with them being advised to contact us, it might be that they just need psychological support or the bladder and bowel care advice, but also give them access to SIA's much wider services, access to our support network coordinators, such as Chris that Angela mentioned, you know, someone that has that lived experience of living with a spinal cord injury or Cauda Equina syndrome. they'd have access to the specialist clinicians like myself. We can also support them to complete emergency care plans. So if they did have to go into hospital again, their care needs would be very clearly spelt out and be very specific for them. So hopefully, the idea is they go into their local hospital, they've got a ready-made care plan, so their care needs should be better met. But as an organisation, we work with trusted partners in the legal side, financial side and the care side, but we also have various business members, and each of our trusted partners and our business members, they're all experts in their own field, and they've all got a very good understanding of spinal cord injury and cauda equina syndrome. So we know that we can signpost our members to any of our trusted partners or business members, and they're going to get the support that they need. But we also have an advocacy team that can support them if there's anything that they're not getting as a direct result of their disability, where if they didn't have a disability, they would be able to access various services. So our advocacy team can support them as well, and as I mentioned, our counselling service. So as far as what's next in the pipeline for SIA, we are continuing to raise awareness of cauda equina syndrome and promotion of the pathway, because once the pathway gets launched, it's often down to the people that are going to be using it to raise the awareness of the pathway. GERFT that helped develop the pathway, that facilitated the development of the pathway, they don't necessarily send out supporting literature, although there is a very good guidance booklet that comes with the pathway. But it is the responsibility, the people that are going to be using the pathway or supporting those with cauda equina syndrome. So off the back of this, we are developing our website further, continuing to collaborate with the NHS and our members and our trusted partners and business members to look at the support that is available for people with cauda equina syndrome. But we want to make sure that we can provide quality information as well. So the website is being updated, so we're putting more and more content onto the website with regards to cauda equina syndrome for both the person with cauda equina syndrome and the healthcare professionals that support them. And I've put on there, just about to launch the leaflet as well. And for our next sort of financial year, I volunteered to develop the cauda equina course, which will be another addition to our SIA Academy portfolio. So our peer support is growing. We do have support coordinators and volunteers that have cauda equina syndrome. And we do support our patients for life, and what we want is for all of our members to be able to live a fulfilled life with spinal cord injury or cauda equina syndrome. And as an organisation and the people that we associate with, we can signpost people accordingly. And we continue to campaign for better care and equity in care provision. We do hold the Secretariat for Spinal Cord Injury for the All-Party Parliamentary Group. So, we do have quite a powerful political voice where we can bring the issues to the attention of the MPs to make changes at the highest level. I shall draw a breath and just say thank you very much for listening.
Thank you very much, Damian. Thank you. Yeah, it was really informative and helpful presentation, and I'm sure everyone on the call will be really pleased to see the pathway. It seems such a positive move, and I think everyone involved in it should be very proud of what they've achieved. I think hopefully in covering it today, we're already raising more awareness of this, and I'm sure people on the webinar today will be taking it back to the organisations they work within. So if any of you have any questions about the pathway, or indeed anything else about the SIA or anything covered in Damian's talk, please do put them in the chat while we have the benefit of having Damian with us, who's obviously been closely involved in developing that pathway. We will take a short comfort break now. I think we're just You actually get an extra 4 minutes on your comfort break. So we're due to rejoin at 2:35. So go get a drink, have a comfort break, and we will start again promptly at 2:35. As they pop any questions in the chat, and we will pick those up after our final speaker, which is Mark, who will join us after the break. Thanks, everyone.
Thank you.
Welcome back, everyone, after the break. I am now pleased to welcome our third speaker, who's been waiting patiently. That's Mark Buckingham, who's a chartered physiotherapist. Mark's been a physiotherapist for over 30 years, working in NHS outpatients, private practice, and in elite sport. And his clinical list is a mix of long-term rehabilitation for patients with spinal and orthopaedic injuries. He also acts as a medico-legal expert, advising on physiotherapy rehabilitation in the long term, and we're very pleased to have him with us today. Thank you, Mark. I'll hand over to you now.
Thank you. Let me just see if I can share up, and I hope that we've just got one single screen of road to rehabilitation on it. Thank you for asking me to talk to you today. As I say, my name is Mark Buckingham. I've been a chartered physio for 30 odd years, and I work in private practice predominantly these days, and I manage a wide range of patients. Some are more able-bodied sports types, but many are also people with syndromes like Cauda Equina, and they make a large proportion of my day-to-day practice. It's not just an outpatient private practice, often seen as just dealing with the sports injuries, and whilst we do see a lot of those, my working day is not just rubbing a magic sponge on a tight hamstring. Equally, we do see a lot of patients with this type of neurological spinal injury, because as Angela pointed out, often when the NHS services finish and it's a very much a postcode lottery, then patients do seek out clinicians like myself to try and help them in any way we can. I note the audience is a mix of legal, case manager, OT, physios, consultants. I hope the next 20 minutes or so will have something for everybody. It will have not too much medical nitty-gritty, but I hope it will provide an overview of how I at least approach these patients when they attend the clinic, and also how I assess them for their future needs. It's pushing, I guess, a little towards the gold standard, as it were, from and a view of what's possible if everything's equal. And as we've also heard, that may or may not be the case for both practical but also financial reasons. So this is more what can be done. I'd like to just ask a question, and obviously Angela has a different view, but can you imagine losing the use of your legs to any degree? Can you imagine suddenly being in a world full of pain and symptoms, the like of which you've never felt before? How would you cope with it? It happens to normal people with normal lives all the time, and it is life altering. It is catastrophic, and the pain in both body and mind, I don't think, can be underestimated or indeed understood by those who are not suffering it. So whilst this is a physiotherapy talk, the key to this is the mind, the ability to push yourself, to never stop pushing against all the odds when the world probably seems totally ambivalent to you, apart from maybe immediate family. That drive to engage with the rehabilitation options, to adapt your life to where you are, and when often it's just not your fault, it's the way the cards have been dealt, as easy as it is to say. As a physio, I can't actually get that patient better. Only they can do this with guidance. They're the only ones that can push themselves to that extent. And I'm not trying to give a psychology talk, but there's a huge amount of psychology in rehabilitation, and it begins in the mind of the patient. They must want it, and they must engage to make any progress. If they do, then there's a lot that can be done. As has already been mentioned, though, not one Cauda Equina syndrome type presentation is the same. The first rule is that there are no rules. There are a huge array of symptoms and severity of symptoms, from a slightly altered gait and some pain to wheelchair bound, incontinent and severe pain and neuropathic symptoms. Therefore, the rehab plan and package must be individualised. It's equally why in this forum rehab can only be discussed in an overview, and the outcomes of that rehab can only again also be discussed in overview, and it's so variable. From a physio perspective, when I'm looking at these patients, working with these patients, also advising over future care via medico-legal processes for these patients, it's very much a, if you don't try, you don't know. And some benefits in some angles are better than no benefits in no angles. So we're not saying we're trying to fix it with all the things I'm about to talk about, but hopefully we can manage it better and improve quality of life because of that. So everything begins with an assessment. We need to identify the limiting factors, which are sometimes significant. They can be directly to do with injury and its severity, or they can be things like age and other comorbidities add into that. Engagement of the patient, as mentioned, is a key. We need to listen to the patient. We need to understand their problems and what's affecting them most. They're the ones living with this. They're the ones who will know best what will help them. As clinicians, we will have those patients whose biggest concern is actually their shoulder pain from transferring or using crutches. Angela mentioned one of her bigger problems was moving around was her shoulders in pushing the wheelchair over any distance. A whole body assessment of range of movement, strength, neurology, control, gait, transfers, functional tasks is needed to build that complete picture and design the rehab program for that patient. That's why physio assessments, when I go out and see patients, can take 2, 3, 4, sometimes 5 hours. So apologies to the solicitors for the bills that follow from that. But the quality of that assessment is also, I believe, what helps the lawyers and the court to understand the reasons for the recommendations made in those reports. And I also hope that a detailed assessment will hold greater weight when making these arguments in court or in litigation arguments. There are numerous measurement tools that can give a view on where they're on a scale, and they can be useful to show progress. They can provide some numbers and percentages and context to a very wide-ranging set of symptoms, and ultimately which lawyer doesn't like a nice measurement or a number. So what does physio do? What can we do to help with these? And it's an overview here. We can neurology with cauda equina, the symptom, the severity and the type can vary hugely, but these can be helped, but to a variable degree and over a variable time, and we'll go into this in a moment. We can help the bad back. The patient still has the proverbial bad back with the associated pain and functional issues that come with that. Associated issues, obviously genitourinary, it's not a physio specifically, but impacts on physio, for example, in hydro or when you have leakage and issues when exercising or pushing yourself. Other health issues could impact on the ability to exercise too, and it's often in the rehab setting that this becomes apparent. Heart issues, for example. Deconditioning, the whole body, cardiovascular, core, limb strength will all have faltered with the devastating effects of this issue and the period of time of debilitation and rehabilitation that follows. And it absolutely can be helped with physio and personal training and gym type work. Quality of life is the big one. We need to identify those areas particularly important to the patient and work towards those. And this has got to help with their motivation and self-esteem. And returning the patient to their work and their play is vital. As medics or so-called experts, we shouldn't, I believe, presume to know what is right for that patient. Rehab must be patient-centered and patient-driven. I always ask the patient what they feel will help them best. And several times this has actually prompted tears as they say this is the first time anyone's asked them that question, often in years, actually what will help them. As medics, we've got to listen to our patients. Physios are also the gatekeeper often in these cases, alongside the case manager, who works with the wider team on the needs of care and accommodation and equipment, pain management, etc. And then as other issues arise and or existing issues develop, referral for other professional opinions. I think in practice, physios tend to see these patients the most. We see them most regularly, and then get that bigger picture. How do we help neural pain? Just to break this down a little bit more. Well, firstly, we got the musculoskeletal stuff. These, as we said earlier, patients still have a bad back. They still have a disc and joint issues and the effects potentially of surgery. And these can all be treated with manual therapy and exercise. Secondly, alongside that, and this is not specific to cauda equina, this is what happens with most people's spinal issues, bad backs. This is the neurodynamics. This is where the altered nerves slide and glide throughout the spine and the legs as affected, and it's linked to stiffness in the nerve and stiffness in the spine and other parts of the body which restrict the movement of those nerves. And it can and does create pain, particularly when you've already got a very sensitized nerve. And it can be affected by physio, improved by physio with both manual therapy and exercise work. Finally, though, we've got the neuropathic pain, and this is the pain that's directly attributable to the spinal cord lesion and causes altered or disordered nerve signals to travel from the spine into the legs, etc. This is the nasty stuff. This is that intractable, life-affecting, miserable pain that has no real sense to it. It's the descriptions are the nettles stinging, the ants crawling, the knives stabbing, the water dribbling, the deep itch you can't get to. It's that kind of stuff that reacts out of all proportion to normal stimulus. Just the pressure of a trouser leg or a skirt or a sock on the leg can cause these problems. It's there all the time, or it comes out of the blue. It stops sleep, it wakes you up, it makes you cry out in pain when it stabs you. It's all of those horrible things. As stated, the musculoskeletal and neurodynamic pain can be helped with physio, but the neuropathic pain is actually really hard to manage. Normalizing of the nerve dynamics and spinal motion is helpful. You help to create a more normal, as much as possible, environment in the spine for the nerves to exist. And exercise and strengthening and control helps too, but it's no doubt it's really tough, and there are no guarantees to any improvement or for how long and when. And I defer to the medics on the medications that can affect it. That's not my bag as a physio. So how do we treat the backs? What do we actually do? Well, physio with hands-on manual therapy for spinal stiffness and the joint mobility. This is the digging in, the poking, the prodding. The disc healing is essential, as it seems to always get lost in the headline of all the cauda equina symptoms. You still got to treat it as a bad back. You then work at the strength and the control of the trunk and the core muscles, and that's exercise based, which is graded and progressive, and obviously limited sometimes by activation of muscle groups. It's physio driven, but later on can also become personal trainer driven. And other inputs such as gym classes, Pilates, etc. can be good as appropriate to that patient. Spinal mobility. The patient has typically had a bad back for some time, and they've certainly got stiffness, which is treated with hands-on work and exercise to restore that normal movement pattern. And that's not just in the area of the spine that suffered the injury, but this is generally through the whole of the spine because of the lack of overall mobility. And it must be recognised there's a huge amount of pain and fear of movement patterns, which is understandable. The thing hurts, and you've had this catastrophic issue that's arrived in the spine, and people become very worried and fearful of movement. And if things hurt and if things react in a very unusual and amplified, exaggerated way, it can really petrify people to not move at all. And development of movement pattern and understanding how that they can move again is hugely important, but it takes time and it takes courage on behalf of the patient. Neurodynamics, as we discussed, is part of a neural type pain, but the neural system and its mobility is as integral to the body as the core muscles, the spinal joint mobility and control of movement. If the nerve doesn't slide and glide as it should, then it generates pain, especially in a nervous system that is already highly sensitized. Functional work is clearly the ultimate aim of all of this thing. Once we have mobility and the control is better, then building dynamic movement patterns are essential, as that patient is able to do. And it may be something simple as walking, it may be cycling, or it may be steps or stairs. It may be, in severe cases, just able to bend a bit more and to transfer without triggering pain, or to sit for periods of time without stirring things up. Unfortunately, physio, this type of work often does flare pain up and causes irritability of all sorts of symptoms, and progress can only always be sort of touchy-feely, if you like. There's no linear progression or timetable you can apply to it, as much as from a legal perspective it would be nice to be able to state and set that out. No one patient reacts or progresses at the same rate, at the same time, or to the same distance. Hence is why, from a legal side, we often ask for these big blocks of treatment over many years, because it just takes time. Weakness, well, how do we manage weakness? What does it work? I mean, effectively, simply put, there's a blockage between the brain and the muscle where the injury has occurred. This is where the nerve is damaged, if you like. There's this kink in the hose pipe when the brain says move, but the message doesn't get there, or only partially. There's no water, it's just a dribble from the hose. The tap's fully on, but nothing's happening at the other end. And apologies to the medics for that analogy, but hopefully it gives an idea that that's what people, they try and make it happen, but this doesn't outgo, or just doesn't go as they want it to. It varies from time to time, day to day, week to week. It may recover, but to what degree, sadly, we can never really know. Only time really tells us that one. It often takes years, and in my experience, more years than the 2 to 3 that are often stated, although the majority does change within that period of time. But I've had patients who 10 years after an injury regain some function, totally out of the blue. Limiting factors often are age and other comorbidities that they may have. Broadly, cauda equina affects the nerves in the legs in general terms. I'm not going to list them. Each level does slightly different things. For example, the L5 nerve supplies the nerves to the muscles that raise the foot and the big toe. Can all these things be affected and improved? Well, in the early stages, absolutely. And as I say, to what degree is hard to predict, but regardless, they need to be stimulated. This weakness, these muscles need to be stimulated, they need to be worked, they need to be pushed, it needs to be all day, it needs to be every day, and in all sorts of environments. And obviously physios can't be with the patient all day and every day, so therefore a lot of that drive has to come, as I said earlier, from the patient. Equipment can be really useful, and obviously early and more regular access to that equipment is the key factor. But and again, as touched on, sadly the facilities in general in the UK can be sparse, and many cauda equina patients are discharged without having had any access. So I think, what was it Damian said, about a third of all, only a third of people cauda equina symptoms get to a spinal unit. I'm not here to bash the NHS. It's expensive in both time and kit, and the NHS just doesn't have the resources or the setup for these patients, and it also seems to very much be a bit of a postcode lottery, as I mentioned. I'm sure some may be bristling who are listening to this about that assertion, and the politics of it all is not for this talk, and I'm certainly not the man for politics. Hence, though, these patients do tend to find clinicians like me in private practice, and we need to do our best for them. Obviously, from a legal perspective, the money from litigation helps enormously, but where the money is not available, it can become really very difficult. Associated issues, well, a huge area, and often the biggest area of concern for the patient. It's often dominated by the incontinence, the sexual function stuff, the numbness, and those are not my areas or this talk. The ones that I see from a physio perspective, shoulders and wrists often suffer from the transfers and the crutches and the wheelchair mobility, as Angela mentioned. Strength control, mobilisation can all help. Correct crutches, correct mobility age, home adaptations also help. but sort of straying a little more towards the OT and care territory here. And as my mother-in-law is an OT, I dare not do that. Posture, enforced sitting, lying brings its own issues of stiffness and pain. Neck and shoulders are often one of the most common areas that I work on. Mobilisation, strengthening, posture correction, equipment, education, proper CT, IT equipment can all help, and obviously go into those recommendations that we make. Deconditioning, these patients have suddenly lost much of their fitness and their strength. It has huge impact on their well-being and their ability to manage themselves, and physio can help with this in many ways, but also a personal trainer can really help this, which leads me on to what a long-term package of rehab care could look like. Well, I'm going to refer to this, and for no particular reason, as the physical conditioning team, and that's me. That's not anything more than for the purpose of this chat. The physio tends to be that gatekeeper. It's complemented by the PT, the personal trainer, and the gym work. Typically, the physio will manage the bits that are directly affected by the cauda equina stuff, and it will work with the patient to keep the rest of the body as conditioned and as pain-free as possible. But there's a lot of overlap, and the key is finding the right physio and the right personal trainer setup. And as Angela rightly said, it's not easy to do. Soft tissue input can be hugely beneficial, and by that I mean massage and soft tissue therapists, and it helps pain management, and it improves function by maintaining good soft tissue length and reduces tightnesses and spasm from prolonged inactivity and sitting and altered gait. It also frees up physio time to concentrate on the spinal, neuro, and more specific rehab work. So a combination of the physio, the soft tissue work can work really well. Hydro, it can be hugely beneficial with and without physio, and I'm going to discuss that in detail in a mo. Electrotherapy type work, additional input from stim machines could be helpful, but it's, in my experience, quite an individual basis. TENS, those sort of electrotherapies, pain management can be helpful. Again, individual. Others find more holistic inputs such as acupuncture helpful, and I noted Angela is one of those, and it can work. No idea how. I've used it for 25 odd years, and it does, or at least the patients say it does, which is good enough for me. Breaking it down a bit further, there are often huge number of hours recommended in reports for physios, which may raise some eyebrows in that legal fraternity. But what would I do in a session? What do we actually do? My colleagues will probably roll their eyes at the old joke, but we are known as the physio terrorists. We make people do the things they don't want to do. We push the sore bits, we stretch the tight bits, we cajole and bully people to work hard when they're tired and in pain. We're really not very nice people. Spinally, we do a lot of hands-on work to the spine and the nerves and the tight muscles of the spine, but also is in those areas that are overworked due to lack of activation elsewhere, the upper back, for example. Leg tightness and spasm needs that hands-on work to free it up and restore functional range and allow functional range and the muscles that can work, albeit partially, to work as well as they can. An example perhaps would be the common weak foot dorsiflexion, or the weakness to pull the foot upwards, which leads then to tight calf muscles, which leads to tripping when you try and walk because you can't get your toes out of the way of the step or the carpet even. We'll stretch and lengthen that calf muscle as well as to work on the weak dorsiflexor ones, or to pull the foot up to overcome that tightness. Sometimes use of splints can also be useful in this scenario. So that's an example of the type of thing we can do. We'll beat those muscles up, we'll stretch them, we'll pummel them, and we'll then encourage those muscles to work through whatever exercise it can be. Exercises, they're so individual, but they're based around the core, the trunk control, the limb strength, and it's a whole body assessment, and it varies and changes all the time. Stimulators, well, handheld or bike function, FES type machines, which often get recommended and asked for. They can be used to activate muscle groups and build strength. They can be very useful for some, not so useful for others. The fancy exoskeletons can be useful, but are also, in my experience, quite time consuming and sometimes can be less rewarding than they're hoped for. I find that these items are typically best used in an inpatient rehab setting, and those with more experience of that than I may be able to add to that. I find it useful with these patients to perhaps go off for the residential type stuff if that's available to them, and basically trial these things and see how they manage with them. Are they of benefit? The ultimate aim of any exercise routine, though, is to develop them into a functional movement patterns designed to improve the day-to-day movement and life of the patient, and that's still got to be the aim of all rehab. Finally, patients often have issues in other parts of the bodies due to the strain of moving and living with the various limitations that they have, and these need to be assessed and treated as they arise. Shoulders are typical, overload, tendinopathy, etc. are part of those. How can we deliver physio? This whole range of different things. Well, it's a combination of lots of different groups of people. Residential stuff, I think the multidisciplinary team can be excellent. Royal Bucks, Steps in Sheffield, there are others, any various different units around the country, and if we can get access to those, although as we say not many can or not enough can, and it's a really good way to get a patient who had little input for a long period back onto a program, just to get all those boxes ticked. And it's often the case, and when they go, they may have finished their NHS care many years ago, and have just none of these things have been followed up and changed as they've evolved. I like it as a clinician working in private practice because it gives me that regular set of fresh eyes and an overview, particularly if they can perhaps repeat those views, once a year, once every couple of years. And it can get, as a clinician seeing this patient, it can get a little bit sort of wood for the trees, if you like, after a while. And having that set of clinicians to sort of just step back and take that overview is really useful. I think it also helps the patient a block of time to focus purely on their rehab, no life distractions, as it were. And it allows them to try various bits of kit like the exoskeletons and different stim machines and hydro and things like this. And it helps them also to mix with others in the same or similar condition, which is huge for the psychology. The downside obviously is costs and access. Home-based DOMI physio can be good if it's available and it takes away the stress and the negative effects of transport. Treatment can be painful and pain-provoking, and home treatment allows the patient to rest afterwards without having to get out of the clinic and get home. The cons are, as Angela says, the right physio is not always locally available or even provide home clinics. Equally, also some clinics have good equipment which may be beneficial for the patient to use, and attending the place with other people in the same position can be useful. So individual as ever. Home facilities really from a must. Proper inpatient specific kit and dedicated space to work on it is really useful, and it allows the patient to do a little and often and removes that stress of transport. Access to a gym, though, having said the above, getting out of the house and going to a place which has people working out creates a sense of community and motivation. Living at home with something like this can be very lonely, and motivation can drain away quickly. I think having that combination of PT motivation, adaptation of the program, developments and progression, and perhaps a combination of home gym and access to a PT in a gym is the ideal combination of. Coming towards the end now, but I just wanted to make the case, if you like, for hydro. The therapeutic case is clear, even if the specific research isn't there. I first worked in a hydro pool around 30 odd years ago, and it was often the game changer for many, just that transitional process. Simply put, it reduces pain and it calms the neural system, but it also allows for that progressive partial weight bearing exercise, so useful when regaining walking without struggling with crutches, the impact on the shoulders and neck, etc. Limitations are obviously accessibility, and it's difficult to find a local facility with a physio, plus obviously time and cost. Also, a specific appointment once a week or so can reduce the effectiveness. It's too time specific. The patient may be in pain. There's the stress of getting there, getting changed in the pool, etc. Then the stress of trying to get something done in the allocated time all affects the benefits. And then you've got to get out and get changed and get home. And it's often really tough on the patient. And continence in a public setting, if you like, is often a worry. A home facility allows for it to be used when the patient is ready and is right for it. And it also allows the patient to benefit from pain reduction when needed, and they can do a little and often at any time of the day or the week. Cost obviously is an issue, space, maintenance, housing, mobility. Barristers also seem to dislike presenting the argument. It sounds like you're asking for I don't know, a home spa. It's far from that. It's like saying physio is a skin polish massage with wow music and smelly candles. It's not that. So a rough overview, it's got to be individualized, as we say. It's a lot of physio input. The progress is slow, blocks of specific work, and then access to physio throughout life for the inevitable issues that arise. Pain limits hampers progress. There are good days and bad days, both physically and psychologically. The patient's got to go on, and the time commitment is huge, and finding the right physio is often really tough. In summary, I believe the residential reviews work well, and that a fresh arm's length view is useful, plus access to lots of specialist ideas and other people in the same boat. PT and gym's not for everyone. Home gym might be better suited to their life and personality. For most, a combination works best. Soft tissue helps. Hydro is really valuable. So some ideas, I hope, there on physio provision once out of the acute rehab phase. Obviously, gold standard is, it's, if you like, there, and not everybody sadly can have access. I maintain, though, that mindset is the absolute key to this, but is no doubt the toughest bit. I've got no idea how I would cope. I've no idea if I'd be able to do all this work as described and still ultimately have pain and disability, but people do, and I hope, without being the least bit patronising, ordinary people become extraordinary in the face of this sort of adversity. And we as physios, medics and lawyers can only try to help them in the way in which we can. Thank you for listening.
Thank you very much, Mark. Really, really helpful presentation. I think to everyone, as you say, sort of across the audience. I think before we started, Angela was explaining to us just how her physiotherapist kind of keeps her going at the moment. It's not just a, I think it just shows that it's not just a nice to have add-on, but something that's essential. I will just I'll hand over to my colleague Gurpreet now, just to see if we've had any questions for the Q&A, and who might be able to address those.
Brilliant, thank you, Lindsay. We've had a couple in of questions, and I'll just go through them with you. I'm wondering if actually Mark and Damian might be able to address this. Do you have any experience with rehabilitation of scan-negative Cauda Equina syndrome, and does this rehabilitation differ from Cauda Equina syndrome caused by compression of the nerves?
I'll let you go first, Damian.
Thank you very much. I guess what you mean by scan negative Cauda Equina syndrome, Cauda Equina syndrome that's not picked up via an MRI scan. Hopefully that was what was meant. I think the work that I did with GERFT, with the development of the Cauda Equina, suspected Cauda Equina pathway, it did show that there's quite a high significant number of Cauda Equina syndrome that's not detected on an MRI scan. It is the sort of clinical examination, looking at those associated red flags, as well as doing a post-void ultrasound, see if the patient's in retention. So you're not solely relying on the MRI scan results. You are looking at the more holistic picture and presentation that patient's coming in with. I guess as far as rehabilitation, if they're scan negative, I don't know whether the question is, are they therefore not being diagnosed with Cauda Equina syndrome because they're scan negative? Because you can, like I say, you can still have a negative scan, but you can still come up with a diagnosis that a patient does have Cauda Equina syndrome with everything else that they're presenting with. So from a rehabilitation point of view, it shouldn't really make much difference, depending on what the actual cause is. I guess, you know, if there are other comorbidities, whether it's anything sort of metastatic spinal cord compression, that would mean that, you know, the treatment of that needs to be added into the equation. That would impact on the rehabilitation side of things. Sometimes, you know, dealing with the cause of the cauda equina syndrome, that might need to take priority before rehabilitation can then continue.
Yeah, from the rehab perspective, Dan, sorry I'm butting in, but absolutely, it depends on symptoms. You treat the patient, you treat the symptoms, you don't treat the scan. So whether it's had a positive scan or a negative scan, you treat the patient and you treat those symptoms as they present. So no, the rehab doesn't differ. You still treat the patient.
I think the only thing I would add onto that is that if someone's got a negative scan, whether that precludes them from actually getting onto the pathway for treatment.
And Mark, you spoke earlier about you've had obviously there's patients that may have function improvement 10 years on, or you know at any time. But is there an optimum window to have sort of the optimum physio? What kind of window you're looking at for having better functional outcome?
Yeah, it's over that 2 to 3 years, ideally. Sadly, we often see these patients through the medical legal process that are perhaps 4 or 5 years down the line that have had sort of blocks of time, years that they've not had any input at all. That doesn't mean that their window of opportunity has gone and it's not to be, can't do anything with that. Certainly, I would still say you work with them, you push it, you try everything. You'll never know what you haven't got, and had you had earlier rehab, what you might have got differently. That's just a complete unknown. But I don't think it's right to say, oh well, they're 3 years down the line, therefore it's not worth bothering at all, because we do see these patients change enormously, even 4 or 5 years down the line. But in answer to your question, the optimum time is that 2 to 3 years, and obviously the sooner the better as well. So.
Yes, of course. And before we let everybody go, Angela, thank you so much for sharing your story. Do you have any more challenges planned?
Well, I am thinking of doing something like a half marathon to raise money for the SIA.
That sounds incredible.
To support them. I'm not sure when, but my head would like to do it. I have done 2 marathons before my injury, so that's probably my goal over the next few years, to try and do that, to give something back for all the help and support that I've had.
Amazing, that sounds incredible. And thank you to everyone. I'm just going to hand back to Lindsay now to close off the webinar.
Thank you. And thank you everyone very much for attending the webinar this afternoon. A huge thanks in particular to Angela for sharing her story so openly and honestly with us, and for all of our speakers for giving up their valuable time to share some of the knowledge with all of us today. There is a link to the feedback, if we can just remind everybody that that's in the chat. If you can complete that, should only take a couple of minutes, but it's really helpful for us to be able to know what it is you want and to plan the future content and what you find helpful. We also just wanted to take this opportunity to share details of some of the fantastic charities we're privileged to work with. So if there's anything that can help you signpost for you, your clients or patients. There's some, we're very privileged to work with various charities, and we've seen today just from Angela's story how important they can be to the patient journey. And then finally, just to highlight, we do have, as we mentioned, a 4th webinar planned for early in the new year, probably February 24. We're just finalising the dates and speakers for that. So details will follow if you've signed up previously, but also make sure you look out on our website for details of that and on our social media channels. But otherwise, thank you very much for joining us this afternoon, and enjoy the rest of your day. Thank you.